I think it's time to start. Okay. Welcome, everybody. My name is Joanna Szojring-Wielgus. I am a member of European Parliament from Poland. I am S&D coordinator from FAM committee as well, and vice president of European Parliamentary Forum as well. Thank you all for coming, as always, like we have a meeting like that. And thank you, EPF and to Neil for organizing this evening. It's my pleasure to chair today's presentation of the 9th edition of the Contraception Policy Atlas Europe. Since 2017, we have been presenting this map to show, compare and discuss the policies about contraception in Europe. The Atlas scores the whole European continent, also outside the European Union, in the fields of contraceptive supplies, counseling and information. We do that around Valentine's Day to remind ourselves that this day is not only for flowers and chocolates, but also for talking about sex, about contraception, and about women's rights. In 2026 in Europe, access to best healthcare should not be different depending on where you live. But unfortunately, you will see that access to contraceptives is different from one country to another. The Atlas shows several regional trends that shapes access to contraceptive today. First, we are witnessing a rise in pro-natalist policy agendas. I think that Neil will explain what does it mean in countries such as Russia, Slovakia, Hungary and Turkey. Pro-natalist approaches are changing the policies around reproductive health. This leads to increased restriction on buying contraceptiveness and to less information about it. Secondly, access to information about contraception is challenged by disinformation and blocking evidence-based knowledge. That happens more and more online and on social media, where no one can control it. The effect is that people don't know the truth and they can't make choices about their bodies, health, and their families. Finally, the Atlas shows how family planning is becoming more influenced by pseudoscientific methods. This includes apps about family planning that lie to women. They ignore medical facts, ignore evidence, and unfortunately, many women and girls believe them. Together, all this shows that the situation is not as good as people think. Still, not all women in Europe have access to contraceptives and to evidence-based information. That is why it is important to talk about it, and thank you so much for being with us today. So, I am very pleased to welcome you to our event today, and I am also glad to present to you the other speakers of our meeting. Melissa Camara from Greens, my colleagues from the FAM committee. Julien Guiffer-Valentin, my colleague from European Parliamentary Forum, but from French National Assembly. My long-term friend Neil Data, EPF Executive Director, who will be presenting a map from us today. Tim Richter. Oh, he's not with us. Yes, it is with from EPF, who will be organized the quiz for us, like every day we are doing. And our two speakers, Dr. Michelle Cooper from the University of Edinburgh, here, okay, and social media influencer Diana Czerny. Dina, I'm sorry, Dina from Indonesia, Czerny. Okay. And I would like also to say that our event is streamed online, and we are welcome our virtual guests. For the people online, I have information. You can also ask a question online and our team will answer it. And now we start the quiz, and I would like to ask Tim to start with this. Tim.
Yes.
It's yours.
Thank you very much. Yes, I'll get us started with a quick quiz. You can just, in case you haven't done so yet, log onto the public Wi-Fi that is called EP Visitors, because you will need internet access for this. Okay, and then what I want you to do is log on to mentimeter.com. That is MENTI and then meter.com. Oh, just menti.com, MENTI.com. And in the chat, you will find a code that you can type in to access the quiz, because I want to test all of your guys' knowledge beforehand. It should be in the chat, but also you can see it on the screen. I can read it aloud for anybody who can see it. That would be 56452898. 56452898. It's just a brief little quiz, and I will already say that the winners will get prizes, so do your best. Okay, is everybody logged in? Okay, I'll wait for another minute. We're good to start? No? One more minute. Should I read it again? Okay. 56452898. Five, 6, 4, 5, 2, 8, 9, 8. Okay, I think I'll get started with the first question. Oh, look at all the players we have. Lots of different icons. I see you chose them well. We have a snowman, alien, Santa Claus. Wow, 34 players. Okay, here we go. And I should also say the faster you answer, the better. What is the most used form of contraception in Europe according to the UN? Most used. Is it the male condom, the pill, IUD, or the implant? Wow, and the majority went for the condom, but it is the pill. Exactly. Most used form of contraception. 15 people got it right. But that is a very common misconception, yes. Okay, let's move along to the second question. Which of the below contraceptive methods is the most reliable according to WHO? Male condom, combined oral contraceptive, spermicide, or implant? Okay, the majority knew that. Very good. It is the implant, indeed. Okay, next question. Which country did more for contraception coverage for young people, therefore increasing its score by roughly 19% since 2020? So this one you can't know. It's from this year's atlas, but you should have a guess. Belgium, Ireland, Slovenia, or Estonia? Ireland. And the majority knew that again. Good job, everybody. Forty players are ready for the next question. How many countries provide emergency contraception, or EC, free of charge at pharmacies or public facilities? 3, 8, 14, or 22? And sorry, the question is, of course, about in Europe. How many countries in Europe? Eight countries, 11 people get it right. Next question. Let me see if that works. Something shown. Which European country still only provides emergency contraception with a prescription? Hungary, Turkey, Slovakia, or Kosovo? It is indeed Hungary. Very good. The majority knew that too. Oh, sorry. I got to go back. How many European countries have excellent governmental websites about contraception? 9, 11, 17, or 23? It's an important tool. How many European countries have excellent governmental websites? It is 9 countries. I wish it were 11 or better 23, but no, it's 9. What percentage of European countries offer postpartum contraception at hospital discharge? We'll hear more about postpartum contraception later, but what percentage of European countries? 25%, 30%, 15, or 45%? It is 30%. That's right. Oh, people can still answer somehow. Some people get it right during that time. How many European countries require direct consent for minors accessing contraception? Is it 5, 17, 8, or 12? Five, 4, 3, 2, 1. It is 8 European countries. Now, this one is an open question. You did a good job with the prior questions. This is on you now to start an open dialogue. What would you ask from a member of the European Parliament on contraception policy? What is important? Okay, we see the first one already. Should contraception be free? It's an interesting one. Make it free across Europe. People seem to agree. more visibility, more discussions. We have some interesting points here. I don't have the time to read through all of them aloud because then the presentation will be over. But you're raising some good points, and we will hear more about this in a second. But first, let's see. Here's some of the results. Let's see who won. Okay. Okay, number one, who is Frosty? Frosty, woo! Congratulations. Is it just 3 more? Okay, we have
3 more.
Yeah. We have 3 more care packages to give out as prizes. Oh, let's see. Gabriele, yeah, I think is second. And Johnny also did very well. Very nice. The last one goes to ET. Somebody phone home ET? Maybe online. Well, we can't give the prize digitally.
Yeah,
But yeah. Johnny's can give out in person. I'm sorry to ET who's joining online. You would have deserved a prize. Okay, thank you very much. And with that, I'll take us back to the presentation to Neil Dutta.
Okay, just wait a minute. Thank you, team. Now we know that it's not so optimistic after this data. And of course, now it's time for Neil data, but I would like to tell a little bit more about Neil. I know him very well, but Neil has been at the European Parliamentarium for Sexual and Reproductive Rights since 2004. Neil founded the organization in 2000, so 20 years ago. He has been responsible for its growth to its current membership of over 30-party parliamentary group. I have been lucky to work with Neil since I think 2017 or 2018, especially in Poland. He's a really good expert in SRHR, and the floor is yours. Neil, you can present this atlas.
Thank you very much. Thank you very much, Joanna. It's a pleasure to be here among you, and welcome to everyone. Also, allow me to thank everyone, especially our hosts here, Joanna, Melissa, and also I see Marc-Angel has joined us. So thank you for joining us and welcoming us into your house and here in the European Parliament. And also thank you to the speakers for having made the trip to Brussels, to Dina, to Melissa, to Guillaume, and to my colleagues for having produced this atlas and this event. I think this is the 9th edition of the Contraception Atlas. We tried to do it around Valentine's Day, so that was already a little while ago, but this is why we have the contraception themed chocolates. So we wanted to make sure that there's a positive, friendly, sexy association with contraception, and that it's not just about problems. But so I'll take you through the Contraception Policy Atlas for this year. And so we have a presentation, so I'll take us through that. And it's good that I have a printout because I can't read the slides in front of you. I don't know if any of you can, but I'll try to explain what's being said on the slides. So first, why is contraception important? Okay, I think all of us here know this, but it's good to remind ourselves why contraception is important. and that contraception leads to desired fertility outcomes. Okay, so I think it's important to frame it that way, that it's not just about preventing pregnancies, it's about helping women and couples proactively have the number of children that they would like, whether that's more or less or none at all or many. Contraception can help in this respect. Also, it helps with specifically unintended pregnancies, and therefore it contributes to having fewer abortions. Okay. Europe overall, we have among the highest rates of contraceptive use in the world, and also consequently one of the lowest abortion rates in the world. Okay. But as we'll be able to see, there's a big variation between different parts of the continent. And so the division that ended 30 years ago between East and West is still very much present with us today. Next slide. So here we have an overview about contraception prevalence rates in Europe. Okay, you have the gray line at the top. That's total use of different types of contraception, both modern and traditional. But what you see is the lines crossing, the pink and the blue lines crossing, and this shows an increased use of modern contraception and a decreased use of traditional contraception. So this is good. This means that more women over the past generation, like 2 generations, have been shifting over to using more modern types of contraception, which are more reliable than traditional types of contraception. Next slide. So, in terms of why the Contraception Atlas, even though Europe is doing quite well, and for a long time we thought that contraception was settled in Europe, that we'd solved this like back in the 1960s when many countries had adopted laws allowing for access to contraception. We still have a fairly high number of unintended pregnancies in Europe, 35 per 1,000 women of reproductive age. We have the highest number of unintended pregnancies in Russia and Romania. And I think we need to point out that this has remained more or less, that these 2 countries have remained among the top ones for unintended pregnancies for the better part of the past 30 years. Okay. And the lowest ones are in Albania and Montenegro for different reasons. Altogether, we have almost 6 million unintended pregnancies in Europe every year. And we can see that the breakdown according to different regions is very uneven. The majority of them are in Eastern Europe, more than half, okay, 3.3 million. And then they're spread out more or less evenly in the 3 other regions of Europe, in Northern, Southern, and Western Europe, okay? So we still have work to do, but it's very unevenly distributed. Next slide. I hope you all got this correctly from the quiz, because we've had this slide in the presentation in the same way more or less for the past 5 years. We need to understand the difference between the most popular methods of contraception, which are the pill, condoms, IUDs, versus the most effective methods of contraception, implant, sterilization, and IUD. So you have IUDs in the 2 of them, but implant is probably the most effective type, goes under the skin, stays there, and then a woman is guaranteed the contraceptive coverage for the lifetime of the implant itself. Whereas pills, you have to take that every day, you miss one. Condoms, we know if used correctly, they're good, but there's human error in all of that. So, next slide. So what is the Atlas? Okay, I think many of you here will know what the Atlas is, but maybe just as a reminder. So it's basically a research project that looks at the policies of 47 countries across geographic Europe. So we're looking at the big Council of Europe, not just the European Union. And we take a look at policies, not contraceptive prevalence rates or health outcomes, really policies, and specifically in the areas of access to supplies, access to counseling, and availability of online information. Okay, so altogether 5 criteria, many sub-criteria. You have them in the back here. Okay, so for all of you who want to really nerd out and take a look at all the separate sub-criteria, they're right there. A new innovation as of this year is that we have taken a look at what happens to women in terms of their contraceptive options postpartum. So after a woman gives birth, usually many women will want to have access to contraception or will not necessarily want to have another pregnancy immediately after giving birth. So there needs to be a discussion about and an offer of some sort of contraception. This is called postpartum contraception. We had not looked at this before, and this time we added 2 new criteria on this issue. This is why the scores will look a little bit differently this year compared to previous years, even though in some countries they may end up with different scores, but not much has changed. Next slide. Also, just to emphasize and to thank the expert group that helped us in developing the different criteria and the contraception policy atlas. So we have a very diverse expert group composed of politicians, also experts from the world of obstetrics and gynecology. We have youth, young people involved, as well as NGOs. And different and private sector, and also different sector-specific expertise, such as emergency contraception. So you have the names there with you, and I believe that they're also on the atlas itself. Okay. Next slide. So here we're almost getting to the good part where we show the atlas. Okay, but just a few more preliminaries. So in terms of what are we scoring when we take a look at the contraceptive policies, so first we have a whole big area of access to supplies. So level of coverage, how it's being covered by the national health system. Is there anything specifically for young people? Because, I mean, young people tend to need access to contraception more. And we all remember when we were young, that's a time in our life when we had less financial resources than we do when we become more established in our careers. We also take a look at counseling. Women need to be guided and advised on which contraceptive method may be more suitable for them. And then online information. People need access to information about contraception. There's a lot of disinformation out there, so we'll get to that in a separate segment, but they need authoritative, science, evidence-based information about what type of contraceptive is out there, how it's covered by their national health systems, and which may be most adapted for that time in their life, whether they want access to contraception, let's say when they're at university and therefore they're looking at 2-3 years coverage, or whether it's a different time in their life and they just need a couple of months, or they may be in a relationship and they may want to eventually think about founding a family. So the same woman may have different needs at different points in her life. Next slide. So postpartum contraception. So I've already explained a little bit what that is. That is the offer and advice about contraception after childbirth. Okay. Now, a few things to consider is that women can get pregnant shortly after childbirth. Not every woman knows this, and it's important that they're familiar with this, even if they're breastfeeding. So breastfeeding is not 100% guarantee, and not every woman chooses or is able to breastfeed. So they need to be advised and informed about what these options may be. And there are several types of contraceptives that are rather suitable for women in a postpartum situation. And there's specific WHO guidelines on this. So we took a look at it for this edition of the Atlas. Next slide. Next slide. Okay. Okay. Yeah. Okay. Yeah. So the updated methodology, with the addition of two new indicators, we had to reevaluate how much each of the different criteria was weighed, and so we recalibrated this. So there you have the new scores according to the different categories. So basically what we did is that there was a rather significant increase in the weighting that we allocated to the actual universal coverage of contraceptives. So how they're covered in the national health system, because that's what determines whether contraceptives are really available. We also heavily weighted more access to online information. In part in light of all the disinformation that's out there, we need to have more authoritative, evidence-based information that can guide women and people about this. And we reduced rather significantly the prescription requirements, thinking that access is more important. Next slide. Oh, wait, did we skip a slide? Go back?
Here. No, no, no.
Yeah. And
Here.
yeah, okay.
Oh, yes, this one.
This, okay. All right. So in terms of the best performing countries, we have 5 countries that are in the top criteria. Okay, so the winner this year is France, with a score of 97%, and then followed closely by the UK, Portugal, Luxembourg. We have is Marc-Angela. Okay, but followed closely by Luxembourg and Belgium. So we can see that a number of these countries had been previous winners as well, the UK, Belgium, Luxembourg, and France. So we have a concentration in Western Europe of very high-performing countries in terms of their policies for access to contraception. Next slide. Yep. Then we have the worst performing countries. And unfortunately for that, we have to go further east. And we have a cluster of 5 countries here as well. Okay, so in terms of the worst performing countries, for the first time, it's not Poland, it is Slovakia. Slovakia is the worst performing country in Europe in terms of contraceptive policies, followed closely by Hungary, then Turkey, then Russia, then Poland. And so Poland, not much has changed, but a little bit has changed. Despite a certain amount of political will, undoing things that have been destroyed is much harder than, or rebuilding is much harder than destroying. But I think we can see that there's a certain commonality here in terms of the different countries that are performing poorly. These are all countries which have seen some democratic backsliding over the past couple of years. Women's rights is compromised, we can see that it's the same countries, we'll get to that a bit later, that have experienced some concern about demographic decline and have adopted pro-natalist policies. So we can see a certain cluster there about of these things. And there you have the specific performance on criteria, how it is, why it is that they're not performing well. In some countries, there's need for a third-party consent for minors. Consultations are not fully covered within the national health systems. Very little, if not completely absent, public information about contraception, and so on and so forth. Next slide. So findings, what we have in terms of the positive, in terms of positive policy changes, we have some changes in Austria, some in Poland as well, with a pilot projects in both Austria and Poland, and also some positive changes in the United Kingdom. Next slide. We also have some positive changes in terms of information provision, surprisingly from Azerbaijan, and Portugal came out with a very good publicly funded website. So that increased their score to make them among the top 5 champions. Next slide. In terms of high-level findings, what we have are, in terms of the new criteria on postpartum contraception, we have access to postpartum contraception in the national guidelines of 19 countries. We have it organized at the time of discharge in hospitals in 14 countries. So we have some good progress, but still some more progress to be made. Next slide. In terms of how many countries overall have changed since 2021, of the 47 countries that we took a look at, we can see that there's been improvements in 17 of them 23 countries have stagnated. So that's been about half of the countries where there's just nothing happening there. And then we have a small cluster of them, yours among them, and a few others, which tend to be further east of the continent, which have declined. So at least on the good side is that the number of countries going backwards in terms of access to contraception is small. There's a much greater cluster that are improving, but we need to get our heads around what's happening with the vast majority of countries, not vast majority, about half of them, which are simply not doing anything. Next slide. So then if we take a look at the overall context, okay, so we've presented how these contraceptive policies are evolving over the past year and then the trend over the past 5 years. A few things to point out, okay? One is the rise of pronatalist policies, okay? Now, in a number of countries, there is the actual challenge of declining populations, what's called demographic decline. This is a real issue. So if we take a look at Poland, we project the Polish population is what, about 40 million now. We project that out to 20, 30, 40 years from now. It's expected you'll probably decline by 10, 15%.
Yes.
Okay.
Maybe more.
Yeah.
Maybe more.
So this poses a real challenge for Ioana and people, other decision makers. How will we organize our society? How will we pay for our pension funds? How will we, provide for our social contribution system? So it's a genuine issue. It happens in Poland, a number of East European countries, but also it's a generalized phenomenon in many different places. Okay. Some countries, not all, but some countries and some leaders specifically have decided to respond to this challenge by trying to limit access to contraception and other sexual reproductive health and rights. Instead of taking a look at some of the root causes behind why are people not having as many children as they would like, they seek to penalize women, saying, well, we'll remove access to contraception and therefore force women to have more babies. Another aspect of this has been to stigmatize non-heterosexuality, thinking that the gays basically are one of the reasons why people are not having babies. So we have, and this can be translated into narrative discourse and actual policies and regulations. So we have that happening. And restricting access to contraception for women or blaming the gays is not an actual solution to demographic decline, just to be clear about this, okay? Then another aspect of this is the widespread disinformation and misinformation about access to contraception. There's a whole ecosystem out there that provides incorrect information, which is a problem in and of itself. But then if you just think, this is done through the digital space in many different websites. These websites are then used by AI to then generate its own responses. So we have a double problem here where we have misinformation populating the digital space. And then this misinformation then feeds into AI when people consulted about different questions about contraception. And young people are increasingly turning to artificial intelligence for their daily lives to get answers that they are asking for. So we need to see this problem on at least these two different levels. And then the third one is the professionalization of quackery, of fake medicine, where this is something we highlighted in another report where we have anti-gender organizations, so organizations which are against sexual reproductive health and rights. They don't just spend their time opposing abortion or contraception, or etc. They have devised actual programmable alternatives to sexual reproductive health and rights. And in the field of access to contraception, one thing that they're promoting a great deal is so-called natural family planning, without actually telling people, women, younger women, that this is natural family planning and that there's no evidence base for it. It is based on a set of secularized but essentially religious principles about how human sexuality should take place. Unfortunately, one of them was funded by the European Commission, and this was put a stop to only as recently as last November. But these things can look very convincing. They use all the right terminology, but then in the end, they simply advise young women incorrectly in a very deliberate fashion. Next slide. And then we'll end here. So in terms of recommendations, one of the perhaps the main recommendation to consider is the coverage of contraceptives, and specifically the most effective types of contraception, which are implants, IUDs, etc., within the national health systems. Another one is ensuring access to counseling, including in the different places including different territories. Some countries have a very large territory. We'll hear from Guillaume about France. We need to make sure that there's equality of access even in places that are remote from urban centers. Public institutions have a responsibility in providing authoritative, evidence-based information, particularly now in an age of disinformation. We need to take a look at new technologies that are emerging in this area, including artificial intelligence and fertility tracking apps. This professionalized quackery that I mentioned was done through a fertility tracking app. And then finally, also take a look at postpartum contraception, which is one of the areas we hadn't looked at up until now. So I'll end here. I hope it was interesting. And you have here the atlas in front of you. Okay, and as you can see here, the main trends, we can see lots of green over in the west. Yes. Unfortunately, lots of red and orange over in the east. And it's something that, and quite a bit of orange and yellow in the middle. So it's something that we need to consider. The countries that have been doing well keep doing better. The countries who have been middle are just sitting there stagnating. And then we have a small subset of countries that are in a bad situation and seem to be getting worse, or we don't know how to get out of that bad situation. So that's something that we can all think about together. Thank you very much.
Thank you. Thank you, Neil, for the presentation. I would like to give the floor to Dr. Michelle Cooper from the University of Edinburgh, who is the lead researcher in Europe in the topic of postpartum contraception.
Thank you so much. It's an honor and a privilege to be here, and thank you for inviting me to be part of this event. As you've heard, I'm a gynecologist, and I've been involved in postpartum contraception research for the last 10 years. It's something that I'm very passionate about, and I'm delighted to see that postpartum contraception is featuring in the Atlas for the first time this year. And over the next few minutes, I'm just going to give you a bit of a flavour about why that is so important. So, we've heard that fertility can return very quickly after childbirth. In fact, it can be as early as 3 to 4 weeks in non-breastfeeding women. And since sexual activity also often resumes quickly within a matter of weeks, there is a high but often under-recognised risk of unintended pregnancy unless contraception is started early. Surveys of women will tell us that more than 95% are not planning to have another baby in the year after they deliver, and yet unintended pregnancy is very common during this time. Data from the UK shows that 1 in 13 women will have an abortion within a year of having a baby, and the same number will conceive and continue a further pregnancy during that time, and that's in a country where contraception is free. A more recent Swedish study found that 8% of women become pregnant again in the 2 years after they have a baby, and a third of those will undergo an abortion. And actually that gap of less than 2 years between childbirth and subsequent conception, which is known as a short inter-pregnancy interval, can place the next pregnancy at a higher risk of complications. Just that short gap alone means that the next pregnancy is at increased risk of preterm birth, of low birth weight babies, stillbirth, and an overall increase in neonatal mortality. And that's when you account for all other possible factors that can contribute. And so that's why for many years now, the World Health Organization have recommended a gap of at least 24 months between childbirth and subsequent pregnancy, but there are also additional benefits, even of a gap of 12 months. But starting contraception at this time is not easy. In addition to the issues that individuals can face in accessing contraception at other times, there are specific barriers that exist in the postpartum period. Looking after a new baby, sleepless nights, recovering from childbirth can make it difficult to attend appointments in the weeks after birth to start someone's chosen method of contraception. And it's perhaps not surprising that there are high rates of non-attendance at these postpartum follow-up visits. There may also, as I've said, be under-recognition of the pregnancy risk at this time due to lack of awareness, thinking that breastfeeding alone may be contraceptive, but also there are misconceptions amongst both women and healthcare professionals about the safety of some methods of contraception at this time, particularly in women who are breastfeeding, even though we know from the existing guidelines that most methods of contraception are perfectly safe to use at this time for babies and in breastfeeding women. Research amongst maternity staff shows us that they often feel they lack the appropriate knowledge or training to discuss and provide contraception, and that there's often underutilisation of techniques such as immediate postpartum IUD or coil insertion, which is very safe and can be fitted at any time in the first 48 hours after birth. Lastly, even in countries where postpartum contraception services do exist, such as in my own, they're often inadequately funded or rely on a very small number of highly motivated and enthusiastic individuals to deliver them, and so they can be difficult to sustain in the longer term. Many international organisations now recognise this as an important public health issue and recommend embedding contraceptive counselling and services within maternity care rather than waiting several weeks later to try and reduce some of those barriers that I described. We know that pregnancy and birth is a time when women are already in regular contact with a number of different healthcare professionals who, with the appropriate training and support, can provide opportunities for women to discuss their future fertility aspirations and their contraceptive plans. Importantly, though, this allows women the time they need to fully consider their options, to discuss with friends, family, partners, as we know they like to do, and it really empowers them to have control over their future fertility. In order to be truly effective, though, that antenatal counselling needs to be partnered with access to the full range of safe methods available to start immediately postpartum, before discharge from the maternity hospital or birth unit, if a woman wishes. That should include the long-acting reversible contraceptives, such as our implants and intrauterine devices, which are often the most challenging to provide in these environments because of the need to have an adequate number of trained staff available. But the evidence shows that by doing so, we can not only increase the uptake of effective methods, we can reduce those short interpregnancy intervals and the harms associated with them. We can reduce unintended pregnancies in the months after childbirth. We can lead to quite considerable cost savings to health services. And importantly, this is something that women value in terms of both convenience and ease of access, but also in supporting their reproductive autonomy. With all of that in mind, a few years ago, myself and some colleagues across Europe conducted this survey, which was the first to try and understand more about the current state of postpartum contraceptive provision. It was sent to individual country-level experts, and we received responses only from 28 countries at that time. Of those, 61% indicated that they did not have existing national policy or guidelines specific to postpartum contraception. 50% did not offer any antenatal contraceptive counselling, and amongst those who reported that they did, only 7% offered it on a routine basis to everyone, and 80% reported that they did not provide methods directly from within the maternity service. Of the 20% who did, less than half of those provided the long-acting reversible methods. Now, this survey was a few years ago. I'm pleased to see that things have improved slightly since then, as demonstrated in the Contraceptive Atlas, but it shows that we do still have some work to do. We then asked them, how would you rate current postpartum contraceptive provision in your country, with more than half indicating that they felt it was poor or very poor. And in the free text, there were some examples of good practice, but also highlighting several of the challenges, mainly around the systemic implementation of these services. And I've given you a flavour of some of the comments that came through in the free text there. So as I said, I think it's fair to say that we do have some work to do. But a huge positive step is that, as we've heard today, the Contraception Policy Atlas is now reporting postpartum contraceptive measures for the very first time. I think this will really help to raise the profile of how important this is in the wider context of contraception and reproductive healthcare, and provide some direction as to where we need to get to. Currently, the two areas of focus are on guidelines and whether or not methods are provided at the time of discharge. So how do we get there? Well, I could probably talk for about 10 hours about this. You'll be pleased to hear that I'm not going to. And actually, a lot has been written about this in the scientific literature. But I think as a starting point, it's really important to try and determine the unmet need. Now, we often report abortion rates, we report unintended pregnancy rates, but we don't always report those specific to the postpartum period. If we started doing that and started looking at those data in each of our own countries, it'd be very easy to demonstrate that unmet need. And in fact, those regional data can be a very powerful tool. What can also be powerful, as we've heard, is including specific recommendations for postpartum contraception in clinical guidelines and in policy documents to facilitate a really clear direction and try and reduce some of the variations in practice that we know currently exist. But in order to deliver these services effectively, we need to ensure that healthcare professionals have the necessary knowledge and skills, but also that our information systems are set up to collect measurable outcomes of postpartum contraception activity so that we can assess progress and also identify gaps. It's fine to do all this work, but if we can't demonstrate what we're doing and how we're moving forward, then it's a real problem. It's important that we partner this with improved information for women, both about the harms of short pregnancy intervals, which I don't think many people are aware of, but also to help dispel some of the myths about postpartum contraception safety. As we all know, we're accessing health information in very different ways now, and it's important that we are responsive to that. In Scotland, for example, we've developed a series of short animations about each of the contraceptive methods and how they can be used in the postpartum period. If you follow that QR code, you'll be able to access one of them on YouTube. We're very happy to share it if anyone's interested in using it. And it's been a really valuable tool, and women like receiving their health information in that way. It's something they can watch time and again. It's short, it's engaging, and it also allows you to demonstrate inclusivity and diversity in the visuals more easily than you can do, sometimes in a face-to-face interaction. But of course, what is central to all of these things is advocacy. You don't need me to tell you that, but it's important that we talk about this. It's important that we share why it's important and to help champion the improvements needed within our healthcare systems to make this a reality. Because compared to a lot of other things in healthcare, this intervention is relatively low cost, but very high impact in terms of improving the health of women and babies. And I want to finish with the words of one of those women who had first-hand experience of postpartum contraception. She was actually the first person in Scotland to receive a coil within a few hours of having her baby in one of the maternity units where I work. And this is what she had to say about it. I would recommend it to anybody. I'm a busy mum and I knew I didn't want any more children after my son was born, but it's so difficult trying to find the time to get it sorted. When my midwife told me I could get the coil fitted straight after giving birth, I jumped at the chance. And 18 months later, it's still there and no babies, so it definitely worked for me. I can't thank them enough. Thank you.
Thank you, Dr. Cooper, for the presentation. It was very interesting. And I would like to give the floor to my colleague, Guillaume Guiffier-Valentin, member of the Parliament from the French National Assembly. Like we know, France is the one of the best countries in the Atlas. Guillaume, what France is doing and why we should all be more like France.
Thank you, Joanna, ladies and gentlemen. Permit me first to say thank to Joanna and Melissa Camara, my European colleagues, to the organization of this event with the EPF team, and to say thank to Neil Data and all the EPF team for the organization of this work, and to our partner. And so about the France. So our country is often up as a model in this area, yet behind this success, significant challenges remain. Addressing them is essential to ensure that progress benefits everyone, everywhere. This atlas shows that France is well placed in terms of access to contraception. What factors can explain that? I can see at least 3 factors. The first factor is a large structural network of associations that has played a historic role and continues to be active. Furthermore, this movement has always worked with political representatives to build coalitions that have enabled our country to make progress in terms of sexual and reproductive rights. The inclusion of abortion in the Constitution in 2024 is the last example. For example, The second factor is comprehensive and robust legislation, whether it concerns provision relating to access to contraceptive products, provisions relating to access to support services, or even access to online information. Our legislation is fairly comprehensive and complete. The third factor is that most contraceptive devices are covered by Social Security. And we are constantly working to improve this coverage. For example, since January 2022, contraception has been free for women up to the age of 26 and no longer just for minors. And since January 2023, access to certain male condoms has been free, for example. While this situation in France may seem positive, we are nonetheless faced with several significant challenges. First, as in all countries, we are confronted with the growing structuring of anti-rights and masculinist movements, as well as the spread of their ideology. We have a real issue with controlling the funding of these movements and combating their actions, which always seeks to block access to contraception or abortion. Just last night, for example, in the National Assembly, we heard attacks on the existence of the offense of obstruction abortion, for example. These movements are also specifically target young men. Secondly, we are facing real budgetary difficulties that are having an impact on the work of associations, action of associations, and access to healthcare and prevention policies. And finally, there is a real issue of inequality of access depending on the region, specifically in the overseas region, and certain policies such as a comprehensive sexuality education program are taking a long time, far too long, to be rolled out. Yet there is an urgent need for action. So France has made remarkable strides, but our work is far from over. Defending access to contraceptions means defending the right of every individual to make choices about their own body and future. This is a shared responsibility, one that requires the commitment of citizens, organizations, and representatives alike. So continue in this direction together. Thank you.
Thank you, Guillaume. Even if you are a leader, you have to work. Hard. And now I would like to give the floor to my colleague Diana Ceroni, the influencer, and we will talk about disinformation and in social media. Diana, the floor is yours.
Yeah, thank you so much. First of all, thank you very much for EPF and Neil for inviting me and sharing this stage with me. It has been amazing. And thank you also to our co-hosts, MEP Joanna and also MEP Melissa Camara, for making space this conversation in the European Parliament. I saw the contraceptions chocolate in your own table and maybe also outside. And I have to say, this might be actually the only place in Europe or maybe in the world where contraception is over with smile, with a wrapper and then clear table, and as well as the design like a condom and everything is really unique. And you know, because in online space, the packaging is super different. It's about fear, it's about shame, and it's talk with the wellness, and it's often wildly incorrect. My name is Dina Hairani. I know it's wrong written in here, it's Diana, but my name is Dina, so I just want to emphasize that. In online space, people know me as SRHR Barbie. SRHR is short from Sexual Reproductive Health and Rights. The reason why I want to use the Barbie, it's because I want to debunk and also demystify the concept of Barbie that maybe people think Barbie has to be white, Barbie has to be tall, Barbie has to be like a model and cannot even talk about something super serious. I would debunk that, and I want to present like Barbie can be brown like me, Barbie can be short, and I can talk about contraception and funding as well. So that's the reason why I use the different persona on social media. On social media, I make content in terms of like short form journalism and storytelling content that translate sexual reproductive health and rights policies, data, and lived realities into the language that people can actually understand and use on daily basis. For example, I'm not sure whether you are familiar with Instagram and TikTok. I hope so, especially our MFP, like the reels, explainers, carousels, and also Q&A. My audience is mostly young people or young adults. And publicly, I mean, I'm not that having a lot of followers. It's only 13K at the moment, but I'm gonna go up hopefully after this. And my DMs actually is a daily reality check because every day people sometimes coming to me asking questions and they're afraid to actually ask this question to their parents, let alone the clinician or like even the doctor. But I want to put a little bit side of the joke because I know it's almost the end of the time and I'm put in the back. So I'm an Indonesian originally. I'm a Muslim immigrant woman, and somehow I'm here giving you the best practice on how to actually communicate contraception to the European young people. So if that's not the most 2026 sentence, I don't know what it is. But listen, I'm here not to be a novelty. I'm here because I've learned something that matters for the policy, and I feel like everybody should learn this. If your message, EPF and also MFP, cannot travel on the phone, on the pocket of the phone that actually all young people use, and then, you know, they just see every day, it actually doesn't exist. It only exists in this building. And, you know, it's so hard to actually come here. You need to bring your passport, a lot of screening, and everything. So if it's only created here and nobody actually understand, probably people like in Slovakia or people in Russia and Poland do not even know whatever you are doing in here. I don't want to say it's useless, but that's the reality. You know what I'm saying? And that's literally not for the young people, and that's literally not for the person who actually scared and scrolling in the middle of the night. So let me start with the message that it could come actually from any young people from any European country. This is the message. Dina, is it true that pill actually makes me infertile? TikTok say it ruins my hormone. I'm really scared. That kind of message actually come to my DM on Instagram like around 1:17 a.m. And it's actually clearly captured the whole problem of the contraception itself and then like the public policy. The real public square for young people is not a committee or a parliamentary room like in here, but it's the algorithm. And right now, unfortunately, the algorithm is educating people on contraceptions, whether we like it or not, because they know it better. Like, I don't think that they are even searching something on Google at the moment. They will search whether this kind of issues right or not on TikTok, not even Google anymore. So that's really scary, I know, but we have to actually be agile and also adaptive about this. And I want to just say kudos to also EPF, like the Contraception Policy Atlas Europe 2026. I read the presentations and also the launching. It's amazing. It's super incredibly useful because it gives us actually clear diagnosis and a lot of data, I know, and I feel like this data needs to travel besides this room, you know, like people need to know more, Neil, about this. Like across 47 countries, 21 actually cover contraceptive, the national health system, and include long-active reversible method. I mean, Neil already mentioned all the data. Also, only 12 cover contraception in the national health system for young people aged 25 and below. And only 9 actually only provide exceptional governmental website on contraception. That's really sad, actually. 9 out of 47 countries. And also there are only 8 provide emergency contraception free of charge at pharmacies or public health facilities. And I feel like the sentence that we have to feel a little bit uncomfortable is that Europe has amazing dashboard and policy frameworks, but not enough digital infrastructure that a young person can understand in one single scroll. They have to keep clicking. They have to go through like one certain website or maybe another website, click, and they have to know like the certain keywords. So it means it's not accessible. And if only 9 countries have exceptional official contraceptive websites, we are leaving a vacuum. And as Neil mentioned before, misinformation is very good at filling the vacuum itself. Also, unfortunately, we don't have one Europe on access, like because from this policy atlas, there are certain different scores, like Great to France, that it's always like in the top 1, like 97.9, like Netherlands is 80.8, and then there are a couple of countries with the lowest scoring. Those kind of gap is not only like the statistic that EPF probably doing every year, but it's actually the difference between being able to plan your life and having your life planned by the circumstances, which is, it's really scary. I mean, I'm from Indonesia, I told you, but I live in the Netherlands. It has been 5 years. This is a top 10 countries on the Atlas. And even there, the fine print matters. Like, yes, there is special coverage for young people up to 19 years old. Yes, online information performs very well. And yet, emergency contraception is not included in the reimbursement. And people there, including me, pay tax super high there. And we can't even get reimbursement for that. So I feel like, what's the point? You know, like it's supposed to be also doing good for the people. So what I want to say, even in this strong system, young people still face costs, facing the stigma, timing, and confusion. And that's exactly when phone becomes the first point of care. Not because it's right, not because it's better, but because it's just available and accessible. This is where I want to speak actually as both influencer, as you call, or like advocate or communicator. Like on my own social media account, what perform best is not, unfortunately, it's not like formal health educations or just like a lot of statistic and data. What performs best and actually attracts more young people is when I bring institutions' data into human language. Because to be honest, not a lot of people have like time or like ability to just like sit and then read everything like this. It needs to be translated into something like relatable. What actually affect them if they understand this data? So when I, for example, present the data, when I speak at the Dutch Parliament Roundtable to actually give them the input towards Global Health Strategy 2030, they feel relatable because why? Oh my God, finally there is diversity. And then there is actually young people could be heard and listened by the government. And they're actually bringing like good input. Also, when I speak plainly about the absurdity of like a lot of young people and us to have quote the basic SRHR information on social media. We cannot just simply say sex because we will get banned and shadow banned. Simply, we have to put 53X so that we don't get banned or shadow banned by the Meta. That's the unfortunate thing. Then I said that, and then people, oh, that's true. It's happening with me as well. And then, for example, also the data around when I tell story in a series like, come with me, I will explain you something like this. And people actually follow it and then, oh, I want to know more from you, Dina. So I want to say, in other words, young people engage when the information is clear, non-judgmental, and emotionally honest and relatable. Because when it doesn't relate to them, they will not engage. And when it actually also respect them as a decision makers, not as somebody that needs to be fixed by the system. That means that like this is not only the communications problem, but it's actually the problem of access. And access is a governance questions, and we need to understand that. Maybe not last thing, like I want to tell you what's actually the narratives nowadays dominating in TikTok and Instagram. Not sure how many people have TikTok or like active engaging on TikTok and also Instagram. I know you have like a lot of followers, you too, so it's good that you are relate with this kind of issues. But I am often asked on that platform, like, who are you up against, Dina? Like, I don't want to actually name the platform. I don't want to name the individuals because I'm not paid for that and they're going to get famous after this. So I just want to mention the ecosystem. Like, there are a lot of hormone coaches on this platform and wellness creators that framing hormones as actually as poison. That's really dangerous, especially they have more than 1 million followers. Also, the fear content about infertility and permanent damage, and then they cover it with the religious perspective. Oh, that's haram. Don't do that. Usually it's like that, especially as a person from Indonesia. Natural contraception content that shares much misinformation. It's like, no, pull and pray, you know, it's fine. God will protect you. Literally, that's like happening on TikTok and Instagram, and anti-rights institution and anti-rights narrative that present care as control. Yeah, and the reason these actually narratives win on the social media platform is simple, because they over certainty in world where people feel dismissed, especially when young people feel dismissed. As Neil mentioned before, that there is a youth project that has to be stopped, right? Because they are anti-rights movement. And actually, I get pushback and bullied by them on their platform. They mention like, simply because, oh, this Dina, SRHR Barbie, and I have podcast and program called Sex O'Clock News. So they use all the data, like, look at this woman an immigrant Muslim from Indonesia, and then she has a podcast called Sex O'Clock News. She's teaching kids to have sex before marriage. It's literally wrong, because literally what I'm teaching in that podcast is like how to get preventive and also the access to contraception, comprehensive sexuality education, and also about funding. So just because the name, and then they tweak everything. But you know, I've been there, done that. A lot of bullied all the time. I just make it fun out of it, you know, like if they call me, oh, you're gonna go to hell, I always make fun of it, like see you there as well. So you have to make it fun, you know. Also, there are other things I want to mention. This is 3 myths that I'm constantly correcting on social media. Maybe you never heard it, but it's actually there all the time. Like they said that hormonal contraception ruins your fertility all the time. Like, don't do that. You're not gonna get pregnant. How if like after this you're gonna be infertile? Also, emergency contraception is basically abortion. They love using this. You're gonna kill baby. Look at that in the Bible and Quran. They are not protecting la 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 la. You know, they're gonna use that kind of perspective. And they also said that unfortunately, they said that doctors always push contraception for control and for money, not care. So I try to debunk all the time these kind of like narratives, but unfortunately the opponents, the people that get funded by the anti-rights and far-right wings, is actually sell these ideas instead. Like, no, just track your cycle, you know, it's fine. You will be safe. Put the cycle, the tracking. Also like just pull and pray, pull out and pray. That's always the thing that they are saying, because God will protect you. And I was like, there are 8 billion people in this world. God is busy. Honestly, like cannot. And then postpartum or breastfeeding means you cannot get pregnant. And it's interesting because you mentioned that you can get directly be fertile after postpartum, right? So what I would like to say that I don't want to shame people's choices, but I want to insist on an ethical baseline that everybody deserves the full truth, including what requires training, consistency, support, and what doesn't protect against STI, coercion, and also unequal power. Last, I know I talk a lot. I'm so sorry, but I just feel like this is barely happening, you know, like young people invited. I would like to offer something for the MFPs or like everybody in here. This is the part where I make very practical for Parliament, because I want you to be very close with the young people as well, not like having a distance. You can have like, you can pass actually the resolutions and also fund programs, but unfortunately you cannot out-compete misinformation only with the press release. So what you can do is partner with people who already have the audience's attention. And here's my proposal. And yes, this is me openly inviting you all to work with me, or maybe also another amazing young content creators. Like first, the recommendation. I will spare you one list. This is literally, it's only one. And you don't need to have another menu, because you are actually the expert and you know all the data. You can always ask Neil and EPF about this. You need one move that actually works in the social media ecosystem. And because that's where young people are forming beliefs at the moment about contraception. They don't trust the parent. Unfortunately, they trust the influencer. So you gotta work with them. So here it is. One recommendation: simple, measurable, unavoidable. I'm asking you to make one piece of truth easier to find than one piece of fear. I call it the PIN truth pledge. Since you have strong social media presence, within the next 30 days, your office publish one myth correction, let's say, to post about contraceptions, and you pin it on your account, like you make it like pin, and then you link it to the permanent one-page guide on your official website. Maybe call it contraception in 1 minute. Just one post, one page, and then with the working link, but not only like for IG story, because it's gonna be gone within 24 hours, and I don't want that. It needs to be that. And it doesn't need to be a perfect messaging, but you have to make it relatable for people. And then I must say, stay up, pin, searchable, and also findable. Because if it disappear again, what I said, 24 hours is not a public service. It's just another piece of content, and we don't want that. Now, my offer is equally concrete. If your office takes that pledge, I will work with you, with the EPF as well, to translate it into short form explainer that young people actually will listen, will watch, and share to their peers or maybe their own parents. But make it like relatable, not like a lot of like data, make it stress, you know, because people do not really like seeing the numbers. They love storytelling. They love live experience. Use that people that have the skills to actually deliver that. And at the end, we need the accountability. I'm gonna ensure we all do that. I will ask also EPF to track who is actually post the pin truth pledge, and then we'll follow up with you guys. And I will end with this. If you want young people or the public in general to trust public institution, you have to show up where they live. Not just with the authority, but also with clarity. So the challenge, invite me back, not only as a youth voice or youth content creators, but as a partner to build a public communication bridge between this parliament and also the community. And don't stop with me. I told you, don't stop at me. Work with other content creators who have already heard more from young people better than you. And whether we like it or not, they are part of the public sphere now. And a policy that cannot be understood is a policy that cannot protect people. Thank you very much.
Thank you, Dina. And I think conclude your presentation, education, education, education. Yes, I think this is the most important. I would like to give the floor to my colleague, Melissa Camara, who will comment on the discussion and moderate the Q&A now.
Yeah, I will give you the floor for the Q&A. Thank you for your work. Thank you for your contribution today. What we see is that contraception policies are a matter of priority. And as a French, I'm really glad when I see that map. But as MEP, as a member of the parliament, I also see the path we have to take. We took that path in France, and I hope we'll do so in that parliament. And maybe a first question before to give the floor to the assistant, it's maybe it was one of the questions with the quiz. Say, what would you ask to an MEP to take the path that French took? Maybe I will give the floor to the other question, and we'll answer after to my question. Thank you. It's only it's always the first question here.
Hi everyone. My name is Meerte. I work for Oxfam. Thank you so much for opening the room today to us and to listen to the very interesting interventions. Looking at the Atlas, and I work a lot on international women's rights and SRHR. I'd be very curious to see this sort of analysis for the entire world. But we know that SRHR is a lot under pressure also globally. And I was wondering, as we are in the European Parliament and also speaking to Parliament members, the funding for SRHR is really decreasing internationally. We all know that. But we also have a role to play here in the EU to provide more funding to fund SRHR. We see, for example, that the Trump administration has expanded the global gag rule. That means that a lot of financing will stop also in gender equality and inclusion work. So my concrete question also to the MEPs here is today, how can you ensure that in the next year, when the new budgets are agreed also in Europe, that we increase the investment for SRHR, not just say, oh, we keep it to the same level as it is, that's already more than other countries are doing? How can we really make sure that we fill some of the gap that is now forming? I know it's not a very easy question, but I'd be curious to hear from you. Thanks a lot.
It is a very difficult question, and because we don't have a very strong majority in the European Parliament. Like you know, the European Parliament is now in the situation that we have a very strong coalition with center parties and radical parties. Yes, we see that EPP, everybody, thinks that this is very conservative and central party, but now they are working together very closely with the radicals and with this fascism, we called in Polish parties. And I think this is very difficult to change. Now, for example, in our committee, FAM committee, we still have a quite a quite good majority, but this is not so strong. And every, voting and every directive when we have to have a complete different tactic to do our, our best practice and the best practice. I will give you the example. For My Voice, My Choice. This is the very good initiative, citizens initiative. We are waiting for the answer from the Commission, and now we know because the answer will be on Thursday. But we already knew that the answer it will be not so good. We are disappointed of the answer, and this answer is very conservative because of the whole Commission is very conservative and they are not so progressive when we are talking about the women's rights. And for example, the next subject is new definition of rape. We are talking about that. Tomorrow we will have a voting about this directive. Probably the result will be good, but all the time we don't know the result because of the majority is like a 50-50 for now. And at the end, it is very difficult now in the European Union to change this. It's very difficult to fight with what you said about the Trump administration and this all of the globe situation. But we tried to do, we try to do and we try to change it. But, this is the reality now. Maybe Kamala will talk something more about that.
Yeah, I mean, it's a strange context in that parliament with those new majorities, and we know we are fighting from some wording that I didn't even knew that I will fight. Like for example, foreign feminist diplomacy became a red line. Feminist became a red line in that parliament, and we are fighting. And for example, with My Voice, My Choice, what we saw is that we have to fight with the civil society, because as an MEP alone, as a progressive MEPs, we cannot win without the civil society, without the society. And when they see that we have people with us, that we have a lot of people, because with My Voice, My Choice, we had a lot of signatures that changed everything. And they know that people are looking at what they are, doing, what they are voting. So we have to keep that common front with the civil society, and we will have great victories.
Thank you. Thank you for that question, Mirte. I have 4 points I want to address based on your question. First, we have done contraception policy atlases for all regions of the world. You can find them on the website SRHR Policy Hub, as well as our other policy atlases on HPV prevention, fertility, abortion, etc. But we have contraception covered for all regions of the world. That's one thing. Secondly, but there are different criteria, because here, for example, with Europe, there was a big emphasis on how the national health systems perform. We cannot do this for sub-Saharan Africa, where it's a different level of strength of the state has a different role, and there's a much greater donor dependence. So there's a region-specific criteria. Okay, so you can't compare green with green in different places, but you can within a region. Second, with the United States funding, I think we need to realize some things. I've been, as was done in the introduction, I've been around for a long time. I was here when the global gag rule was installed by George W. Bush, and twice, or during his 2 mandates, and then when Trump did it the first time. What's happening now is vastly different and unprecedented in U.S. history. Okay, so not only is it the global gag rule, that's almost irrelevant. There is no more USAID. And if you take a look at different policy documents from the United States, the US sees Europe as a rival or problematic center. Okay, so we need to understand this. And if we take a look at the best case scenario for the United States, where let's say the Democrats win the midterms and then take back the White House, that's a best case scenario and small probability. even that, they will have so much work to do internally in the US that the US is not going to come back. And USAID is gone. Okay? It's gone. So we need to consider that the US is gone. It's out of the picture for good. Okay, so there's no point in talking about global gag rule or not, you know, it's irrelevant. Okay, the US is gone, and it was the biggest funder in this area. The gap that is left is too big for any of the other funders to fill that. So that's another thing we need to realize. What this means is that countries will have to fund their own development programs in this area. Okay, and which is not necessarily a bad thing. Growth rates in some countries, including in sub-Saharan Africa, are higher than they are, for example, even in many European countries. So that some countries have the fiscal space to do this, where some others may not. And that brings me to, and so they will need to take a look at different types of domestic resource mobilization. This will be done with development partners, with their own state apparatus, with the private sector and other actors. So that's one thing that they need to look at. And if they're serious about this, there's no other solution, basically. And then finally, there will be a number of states that remain fragile, that require humanitarian UN assistance. So that's something that we need to focus on. At the same time, there's the UN 80 process taking place at the moment. So a big reform of the United Nations. And one of the core things of this UN 80 process is a potential merger between UN Women and UNFPA. UNFPA is the largest single provider of free contraceptives in the world in humanitarian and development settings. With this UN 80 process, we don't know where that could end up. Okay, and if there's this UN 80 process and eventually a merger between these two entities, we could have a real deprioritization of women and sexual and reproductive health within the United Nations system. And both agencies were created by UN resolutions. Therefore, to merge them, you have to go through a UN resolution and present this back to the General Assembly. Given the current geopolitical climate, okay, if we present a text to the UN General Assembly with the words gender and sexual and reproductive and health and reproductive rights in there, do we think, honestly, that it can go untouched through the General Assembly? It seems some of our friends in Washington are good using a black marker with a number of documents recently. I suspect they would not hesitate in this area either. So we could end up with a system where we have an imperfect system, but at least two UN agencies looking at women and reproductive health. If it goes through the General Assembly, we could end up with nothing. So I think in terms of the answer to your question, we need to take a look at it at those four different levels.
Guillaume?
Merci, Melissa. Thank you, Melissa. And with my English, sorry for that, but I agree with Neil and my colleagues, and I share your concern about the budget cutting, about the ODA specifically. Today we are in a context where each country cut the budget dedicated to the ODAs, and it's a mistake. There is just one country who don't do that. It's Spain. It's Spain, and I think Spanish friends show us the good way in this period. And in this context, in Europe, I worry about the Global Europe program and Getaway system. Is that which merge the ODA budget with the economic investment international. That is very worrying, because I think it's not a good solution. We have to keep dedicated budget to the ODA, and we have to work about a new financing system, especially, for example, with in solidarity taxes, about the plane ticket or about the financial transaction. I think it's the good. It's it's a good interrogation to have. And last point, as Neil said, we have to pay attention to the reform to the United Nations, because today this reform is just to merge the women UN Women and the UNFPA. So the two agencies who works on the women rights.
Yeah. Do you want to take the floor? Someone else have a question? Yeah.
I just want to point out that it's already 5, so we need to be mindful
Maybe a last one?
because we also didn't hear from you. So.
Yeah. One question, and after we will conclude. Go ahead. Yeah.
So I am like surprised because I came from Albania and I'm Yetmira and I studied in 2010. I was a peer educator for contraception policy in students in the time. And it was so much big change from now. And I'm happy about this. But my question is, why in your studies in contraception policies is not mentioned about gender roles and about family planning? This is a big, big condition of having another data, and that affects very much about your studies and contraception policies. Gender roles, I think, as a person that finished also master in gender studies, affect too much this. So because we mentioned also, I'm happy that today I see that in the like a sort of publicity, there are mentioned also male condom and other, not only to use female protection policies, but also to it based in two genders. Thank you.
Thank you for raising that. On the issue of male contraception, I mean, there's some research that goes into this. That's true, but at the same time, we need to recognize the reality. There's only the male condom that is available to men. Otherwise, unfortunately, with our present rate of with the devices that do exist, the responsibility falls upon women, and that's unfortunate, but that's the reality at the same time.
Is also a female condom, but it's not so mentioned in social media, and
Yeah.
some women are not aware that this exists.
Exactly. Yeah. So that is mentioned in the atlas. At the same time, one thing that we really wanted to emphasize was the most effective types of contraception, which people know less about. People use and are more aware of other types of contraception, which are not always the most effective, namely pills and condoms. People will know about those, but the most effective ones, that there's still some awareness to be built around this, and that's what we chose to focus on. Thank you.
Thanks a lot. So we will have to conclude. I'm really sorry because it's already 5. I really want to thank you all for being here. Thank you for that wonderful work, for your contribution today. And that contraception policy atlas does not simply rank countries, it reveals political realities. It shows us where access to contraception is treated as a public responsibility and where it is not. As you have demonstrated today, in some countries, access is improving. Contraception is better covered by public health system. Young people can access it more easily and without stigma. Public information is clearer and more visible. Postpartum contraception is increasingly integrated into care pathways. They are not abstract reforms. They are concrete political decisions that improve people's life. But we have also heard that in other contexts, the opposite is happening. And we spoke about the far right and the anti-choice movement who are there. We are also here in that parliament fighting back And we are here as progressives to fight back against the backlash. This means that even today in Europe, the ability to decide about our life still depends too much on where we live, actually. That should concern all of us, because access to contraception is not a technical matter. It is not simply about healthcare organization or budget lines. It reflects political priorities. When contraception is fully covered, when young people can access it without financial barrier, when postpartum contraception is offered at hospital discharge, it means equally is treated as a real public commitment. It's treated as a real public commitment. When access becomes more difficult, when public information is weak, when misinformation spreads without response, it means women's autonomy is being questioned. We must also look at the broader political environment across Europe. Pro-natalist policies, you told so, are gaining ground. Pressure on reproductive health services is increasing in some countries. Rights that were once considered secure are being challenged again. And Joanna spoke about My Voice, My Choice. We are waiting now for the Commission response, but we really have to still push on member states and the Commission to have a clear answer, to have a response to all the women we need My Voice, My Choice today in Europe. It requires we need political courage. It requires consistency. And above all, it depends on our collective choices. And we will be there, the progressives, the socialists, the Greens, to fight. And thank you again to be here today.